Assalamu alaikum. Dr. Hussain Baksh Kolachi YouTube channel is with you, and today we will discuss a very important topic: rural health and urban health. What are differences and what are deficiencies and what are inequalities? Are there is urban side more better as compared to the rural side, but most of the people in Asian countries, including Pakistan and South Asia, the rural population is more than 60 to 70%, while urban population is from 40 to 20% in different countries. It is different. But in Pakistan, as the latest figure shows, that 63% population is living in the rural area, and almost uh, 40 uh, percent population or less than that is 37% population is living in the urban area. And in urban area, the few major cities like Lahore, Karachi, Quetta, the most of the urban population is concentrated there, and the healthcare system, healthcare facilities, and healthcare programs are also run from the urban centers to the rural area. So that is another administrative management and policy decision also. And in policies, the National Health Policy 2009 and the earlier policy in 2001 and even in 1997 policy and some other policies before it in 70s. They also focused that this difference between rural area and urban area can be reduced, or the gap should not increase but it should decrease, or equal opportunities be available. Best doctors, best hospitals should not concentrate or focus the urban areas, but they should also spread in the rural area with same quality and attention. And even the budgetary problem or the allocation to the health in Pakistan is most of the years less than 1%, but if it is 2 to 3%, even it is less, because in Western countries and in neighboring countries it is 5 to 7 to 10% at least, but in different developed countries and European countries, the budgetary allocation is more than 10%. Another aspect is the pocket expenditure, or OOP. Normally, we ask this question in postgraduate students, MBBS students, and even PhD students. This means that the drugs and the supplies as well as the laboratory cost, they are paid from your own pocket. That means that from your own income you are purchasing the health services, medicine, supplies, or even the operation cost, even the travel cost. So that makes OOP 70% in Pakistan, and that is a very high percentage and very important. So the universal health coverage and the Alma Ata Declaration as well as the Astana Declaration of 2019 mentioned that the primary health care, quality primary health care should be available without financial hardship, so that everybody can afford it, and it should not increase the financial burden or hardship on any section of the society. So today it was assigned lecture for the MBBS, third year MBBS, but it is a lecture for postgraduate and even for the general public awareness. So let I should uh, upload my presentation so that we can further see that what is the real situation. If I can show this, my presentation from my, so let I should try my level best, if I can locate it. Uh, mm, Cannot minimize it. Yes, now I think the presentation is ready. Yes, yes. So sorry for this gap. This presentation, you can watch it, that this is a urban settlement, high-rise buildings, vertical buildings, and a huge concentration of people, hospitals, doctors, as well as the latest health technology, and even the administrative control is towards the cities. So, rural versus urban health in Pakistan, structure, strength, and challenges in South Asian context, because we want to see the bigger picture also. So let us move to the second slide. You can see that the population distribution, 63.6% of Pakistan population, more than 208, but this is an old figure. But now we have 230, and it is increasing with very fast speed. While in urban population accounts for 34%. So it is now almost 30 to 40%, and the population of rural area is 60%. So the more people are living in the rural area. Budgetary allocation, you can see that as per the GDP, the 0.2% or 0.1%, or if you take it as a 2% even, then the WHO requirement is 5% minimum, so that you can manage the healthcare effectiveness and accessibility. Uneven progress, life expectancy rose nationally from 61 years to 65 years, and now it is 67 years. But as per the economic survey, the average of the Asian countries is 71 and 70. So we are 3 to 4 years less living people in Pakistan, and that shows that how the healthcare system is working. This is an important organizational chart, but you can see that this building is not as strong as it should be if you consider it a healthcare system. So all the columns as well as roof and the bottom both are not as strong or resilient as they should be. Doctor to population ratio can be as low as one doctor for 12,000 in remote areas, and highlighting the staffing crisis. Infrastructure significance gap exists with 14% of clinical equipment non-functional, poor medicine storage, and lack of essential tools like ultrasound machines. Primary health care is a backbone. Basic health units and rural health centers provide foundation to primary health care. Limited specialized care, few secondary or tertiary facilities, with many districts lacking specialized medical care. Even for complicated deliveries, the women are transported from hundreds of miles to the tertiary care. This is a common scene, but access is less, referral link is weak, preventive services are lacking, particularly for immunization and maternal care. And one example is that polio is still endemic in Pakistan, and apart from many vaccination rounds and campaigns, and the polio is a big problem. Recently, from 2 to 8, a campaign had been launched in which 45 million children were supposed to be vaccinated. So 1 million children are still missed, and there is a problem that polio environmental samples are positive. So this is the position. 14% of clinical equipment non-functioning. So how the care and quality will be. So coming to the merits and demerits of urban health system, demerits, let us discuss overcrowding in hospitals and how high out-of-pocket expenses, which is 76%. I was telling you about 70%, but this shows that the data shows 76% people are purchasing drugs, medicine, laboratory tests, and everything. Urban slum population often still face inadequate access and sanitation challenges. Without sanitation, nothing is hygienic, nothing is health. So merit is superior X to specialist and advanced diagnostic services. This is urban health merits. And rural health share, you can consider that the superior access is not but a very less higher health literacy and greater uptake of preventive care measures. But polio vaccine is still a problem in the urban area, and most of the polio workers were killed in the urban setting, not in the rural setting. Significantly low maternal and infant mortality rates. IMR is 40 per thousand, and in rural area it can be more than that. So merits of rural health systems on the same pattern. Geographical isolation leads to increased travel cost and delayed medical attention, low health literacy and cultural barrier, particularly affecting women's health access, higher maternal mortality. While in the urban area, it is 40 per 100,000, and in the urban, this is rural area, and in the urban area, the maternal mortality is 40. So you can see it is a 3 to 4 time difference. And chronic disease burden, hypertension is also one of the problem merits. Expanding community-based program like the Sehat Sahulat program improve financial access, growing telemedicine initiative and mobile health units as in SIUT, mobile dialysis services, and some other programs are there. Even 1122 and 112, these are the facilities I have seen. They are very effective in rural area and saving many people. So, comparative health outcomes, Pakistan versus South Asia. And here you can see that Pakistan rural urban health gaps are more severe than typical regional trends in South Asia. Compare the infant mortality rate, very sensitive income. South Asia IMR is 30 to 50%, and Pakistan rural area is 56%, and urban area 40%. So we are not reaching even the South Asia parameters. Only urban centers they are closer, but the rural area they are 56 per thousand as compared to South Asian average of 40. So 15 children at least in the rural area are dying more in Pakistan as compared to South Asia. Health workforce density. Rural area in Pakistan suffer from low health work density compared to rural zones in India and Bangladesh. Regional success. South Asian countries with a stronger rural primary health care system, as in Sri Lanka, demonstrated better equity in health outcomes. So let us move further. This is Pakistan rural health system is less integrated with fewer resources and weaker referral linkages compared to its neighbors. Uh, we compare this just with Bangladesh community clinics with strong NGO partnership, significantly improved rural maternal health outcomes, and polio is also eradicated in India, Bangladesh, but we are facing this problem again and again. So, coming to the strategic recommendations for Pakistan, expand Sehat Sahulat program, invest in rural health infrastructure, scale telemedicine and mobile units, promote gender sensitivity health education, and faster public private partnership. In Sindh, it looks better, but I think in Pakistan, this is one of the solution. Uh, so this perhaps is the conclusion. Bridging the divide for health equity is important. Critical barriers, transformative potential, reforms, regional insights, learning from the successful South Asian neighbors, call to action, prioritize equitable resource distribution and community empowerment to ensure health for Pakistanis, fostering healthier, more prosperous nation without health is not possible. So with this, I think I am completing, and I have given this insight, but it shows that in conclusion, till people have a smile on the faces, good health is the precursor of the smile. Development is important, and concentration at few centers are islands of the health. Good health will not solve the problem. Nowadays, in the world, health desert concept is also there, in which, in large part, the healthcare services are either weak or absent, and the same phenomenon is in the war-torn countries and in the disaster-prone countries like Pakistan. And even the climate change is making all these healthcare delivery system, not only in Pakistan, but in the other countries also, very important challenge for the uh, people as well as let I should come to the end. So in Pakistan, the healthcare workforce, for example, WHO says that it should be 43 or 44 per 10,000 population, but the latest figure, as by Zafar Mirza, the advisor of Pakistan, a health ex-advisor of Prime Minister on health and very important figure in the public health, uh, has given in the Dawn article that we have only 15 to 16% PNM, physician, nurse, and midwife. That should be 44, and even in Iran, it is 36, and many other countries, it is more than 100 in UK and other countries. So, where we stand today, and even the ranking of the Pakistani healthcare system is at the bottom 20, 30 countries of the world, and that should be at the top because we are nuclear country and we have a strong health workforce infrastructure, but their training, deployment policies, and the moral of the health personnel, because there are many security issues. Polio workers are killed, polio campaigns were politicized, and even all the department forces and agencies like army rangers, they are not on board to solve the polio and other big health problems. Only at the disaster time we see that they are mobilized. So in the rural area, I think the army healthcare services can be integrated, private health services can be accessible in the rural area, and the government facilities through public-private partnership and better monitoring, management, and administrative and policy support, we can make Pakistan a healthy nation, and our health parameters, indicators, social, or even the healthcare delivery indicators utilization can be improved. So, with this, we are ending. I hope if you have any query, particularly the students and the people of other countries, South Asian countries, will see that where Pakistan is, where they are, where world is, and the rural people are actually the most important part of our healthcare delivery system, and we must accelerate, we must increase, and we must prompt it to solve the not only the present health problem but in the future emerging health problem, global warming, as well as the new threats and health security problems in which biological weapons and other dangers are there. Thank you very much. Please like, share, and comment Dr. Hussain Bashkolachi YouTube channel. And as the YouTube policy is that it should have content which should give insight and new knowledge to not only the medical professionals but the users of the social media and this information technology. AI is one of the area where rural healthcare system can also benefit through the mobile health services or M health services, telemedicine, and through the apps and other AI gadgets or programs or facilities we can access and we can record and we can guide them in a proper way. Thank you very much. Thank you very much.